Hello, everyone, and welcome to our module on neuroembryology. So in other videos, I talk in detail about the three germ layers of the embryo that develop into the organs of the human body. And what I want to emphasize in terms of neuroembryology is that the ectoderm is the germ layer that gives rise to most of the central nervous system structures. The surface layer of the ectoderm gives rise to the anterior pituitary, the lens, and the cornea of the eye. The neural tube we'll talk about a lot in this video. It gives rise to most of the major structures of the central nervous system, including the brain and the spinal cord. It also gives rise to the posterior pituitary gland and the retina. We'll talk a little bit about the neural crest in this video. It gives rise to autonomic nerves, sensory nerves, and also the skull. And then finally, besides giving rise to all these neurologic structures, the ectoderm also gives rise to the epidermis in the skin and the hair and the nails. And that's why in other videos I talk about so-called neurocutaneous disorders. These are basically ectodermal disorders, and they give rise to problems in both the nervous system and in the skin. And that's because the skin and the nervous system both derive from the same germ layer, the ectoderm. Okay, we're going to start this video by talking about the development of the neural tube, which is a super important embryologic structure. It gives rise to the brain and the spinal cord. And the development of the neural tube begins with a structure called the notochord. This is an embryologic structure that initiates the developmental process of the neural tube. It is not part of the ectoderm. It's a mesodermal structure, but what it does is it secretes signaling molecules. For example, one of them that's well described in the literature is the sonic hedgehog protein, and these signaling molecules induce the overlying ectoderm that sits on top of the notochord to become neuroectoderm. The neuroectoderm will eventually go on to form the neural tube, although first it forms a structure called the neural plate. So the neural plate, as I just said, goes on to become the neural tube. It also forms neural crest cells. And the neural tube, as we're going to talk about a lot in this video, goes on to form the brain and the spinal cord. That's why it's such an important structure in neuroembryology. All of this occurs in the first few weeks, days 17 to 21 of embryogenesis. And one thing to know about the notochord is that you can still find its remnant in the adult, and that's the nucleus pulposus, which is the gelatinous material that's part of intervertebral discs. And this is the material that can spill out and compress nerves, causing herniated disc syndromes, which I talk about in other videos. And so this whole process is sort of depicted right here in this diagram. You've got the neural plate, which is part of the ectoderm. It's going to involute like this, and then it's going to seal into a tube, and that is going to become the neural tube. Right down here beneath the neural tube is the notochord, and that's the structure that's part of the mesoderm, secreting substances that drive the formation of the neural tube. And just to make this even more clear, here's another little cartoon to remind you that the notochord sits below the ectoderm. It's part of the mesoderm. It's going to tell the ectoderm to form into the neural plate and also the neural crest. Then you're going to get folding of the neural plate, and then finally you'll end up with the neural tube with neural crest cells on the side of it and the notochord below it, and the notochord will go on to become the nucleus pulposus of the intervertebral discs. And here's a drawing of the anatomy of the spine, just to remind you of what the nucleus pulposus is. So we've got the spinal cord in the middle here, nerve roots coming out on both sides. Behind that, you've got an intervertebral disc, and in the middle of that disc is this gelatinous material called the nucleus pulposus. That's a remnant of the notochord. And sometimes this can leak out and compress nerves, and that leads to herniated disc syndromes, which I talk about in other videos. Okay, now let's talk about how the different regions of the brain and spinal cord develop. Remember, the brain and spinal cord develop from the neural tube. So initially, the neural tube is going to look something like what's shown here, and it's going to start to develop these bulges, which are called primary vesicles. There are three of them. First one is called the prosencephalon, or the forebrain. This is up near the top. This is going to become the cerebral hemispheres. Then you have the mesencephalon, or the midbrain, and then finally at the bottom, third vesicle or bulge is called the rhombencephalon, or hindbrain. After this, more bulges are going to develop. So the prosencephalon, the forebrain, is going to divide into two structures, the telencephalon and the diencephalon. And then the hindbrain, the rhombencephalon, is going to divide into two structures, the metencephalon and the myelencephalon. The only one of the three primary vesicles that basically remains unchanged is the midbrain or mesencephalon. This stays the mesencephalon, and that's what forms the midbrain and the brainstem. So basically, the most important thing to know about all these structures are the names and where they're located in the neural tube. Prosencephalon and forebrain up near the top, where you're eventually going to get the cerebral hemispheres, and the rhombencephalon or hindbrain down near the bottom. And here's another diagram just to make this clear. This is the three vesicle stage with the prosencephalon, mesencephalon, and rhombencephalon. Then later on in development, you reach the five vesicle stage where you have the telencephalon and diencephalon up at the top. That's going to form the brain. The midbrain is going to be formed from the mesencephalon, and the hindbrain is going to go on to form the pons and the cerebellum and the medulla of the brainstem. And so from this 3-vesicle stage, you get the 5-vesicle stage, and the 5 vesicles develop into the brain and the brainstem. The spinal cord, in case you're wondering, is developed by more caudal portions of the neural tube down here. Now, if you look at a cross-section through the developing neural tube, you can identify these regions known as plates. So let's look at this drawing up here labeled A. Some of these regions are posteriorly located towards the back of the developing embryo. Those are called the alar plates. And some of these regions or plates are located more anteriorly. Those are called the basal plates. And so the alar plates, which are the dorsal or posterior plates, those go on to develop sensory neurons of the spinal cord and brainstem. In contrast, the basal plates, which are ventral or anteriorly located, those go on to develop motor neurons. And so you can sort of see that in this diagram here. We've got the alar plates shown in orange, the basal plates shown in green, and then the neural tube goes through developmental stages, but eventually you end up with a cross-section like this shown right here through the brainstem, and you've got derivatives of the alar plates representing sensory neurons, and you've got derivatives of the basal plates representing motor neurons in the brainstem. The same thing is true for all the different regions of the brainstem and the spinal cord. Now what I'm going to do for the rest of this video is talk about neurocongenital defects. And the defects that I'm going to talk about in this video generally fall into one of 3 categories. First category is neural tube defects. So as we've been discussing, the neural tube is a long tube that develops into the brain and spinal cord. And if one end of that tube doesn't close normally, that can lead to a neural tube defect. So we'll talk about spina bifida, anencephaly, and encephalocele. These are all examples of neural tube defects. We'll also talk about one special cephalic disorder called holoprosencephaly. And then finally, there are a number of so-called posterior fossa defects. These involve the cerebellum, which sits in the posterior fossa of the skull. And there are a couple of defects in this category: Chiari malformations and Dandy-Walker malformations. Let's start by talking about neural tube defects. So neural tube defects occur when the neuropores of the neural tube fail to fuse and close. So let's talk about what the neuropores are. So remember, the neural tube is a long tube, and it's got an opening in either end. One end is at the caudal end, down near the coccyx. The other opening is at the top, up near the head. And so these openings, which are called neuropores, if they don't fuse and close, that leads to a neural tube defect. Normally, the neuropores fuse and close in the 4th week of development, and there are 2 of these neuropores. The rostral one is up near where the head is going to form, and the caudal one is down near the tail. So spina bifida, which we'll talk about in a second, happens when the caudal neuropore fails to close posteriorly. As a result, you don't get bones developing around the spinal cord and meninges. At the other end of the neural tube, anencephaly, which literally means without head, occurs when the rostral neuropore fails to close anteriorly. This leads to absence of major portions of the brain and the skull forming normally. The risk of developing a neural tube defect in a baby is related to a couple of factors in the mother during pregnancy. Biggest one to be familiar with is decreased folic acid intake. We tell women who are pregnant to take folic acid vitamin supplements, and that's because we want to reduce the risk of neural tube defects, which are more likely if the woman isn't taking enough folic acid in her diet. Neural tube defects are also associated with type 1 diabetes and obesity, and they're also associated with certain medications if taken during pregnancy. The biggest one is valproic acid, which is an anti-seizure drug, and also carbamazepine, another anti-seizure drug. Okay, so now let's talk about spina bifida. So spina bifida is when that caudal end of the neural tube fails to fuse and close. So it leads to a little bump on the spine, like what you can see right here in this baby, and that's because bones didn't form around the spinal cord down at the lower back. There are 3 forms of spina bifida. The first is called spina bifida occulta, which we'll talk about now. The other 2 forms are called a meningocele and a myelomeningocele. So in spina bifida occulta, you get failed closure of the posterior or caudal neuropore. This is true of all forms of spina bifida, including spina bifida occulta. As a result of this failed closure of the caudal neuropore in spina bifida occulta, the vertebral arch does not form properly around the spinal cord. You can see that in this drawing here. There's no bones right here sitting over the spinal cord in this region, depicting spina bifida occulta. Despite the absence of the vertebral arch, in spina bifida occulta, the meninges in the spinal cord stay in their normal position. They do not herniate outside of the spinal column. The dural layers remain intact, and basically, the only exterior evidence that the vertebral arch is missing is that there's usually a tuft of hair over the skin at the level of the defect, and that's what's depicted right here. Because the spinal cord remains in the spinal column in its normal position in spina bifida occulta, there are usually no neurologic deficits. And spina bifida occulta is an example of a closed neural tube defect, and it gets the name closed because the neural tissue, meaning the spinal cord, is covered by skin and is not exposed outside of the body. So spina bifida occulta is the mildest form of spina bifida. Now we're going to go up one notch in severity and talk about a more severe form of spina bifida, and that's a meningocele. This also occurs due to failure of the caudal neuropore to fuse and close. This also involves failure of the vertebral arch to form properly, just like spina bifida occulta. But what's different in this condition is that the meninges herniate through the bony defect, the place where the vertebral arch is missing. And that's depicted here in this image of a meningocele. We've got the meninges sticking out through the area where you don't have the vertebral arch formed normally. This results in the baby being born with a little sac at the bottom of the back that's filled with cerebrospinal fluid. Importantly, though, in a meningocele, there's no herniation of nerves of the spinal cord. They remain in the spinal column like they're supposed to. And for this reason, neurologic function is usually normal in babies born with a meningocele. And in most cases, a meningocele is an example of a closed neural tube defect. And that's because, although the meninges are herniated through the region where there's no vertebral arch, the meninges are covered by skin, and that keeps this defect closed so that you don't have meninges exposed to the external environment. Okay, now we're going to go up one more notch in severity for forms of spina bifida and talk about a myelomeningocele. This is the most severe form of spina bifida. In this condition, once again, you have failure of the caudal neuropore to fuse, and once again, you have absence of the vertebral arch. But in this situation, you get herniation of meninges and spinal cord outside of the baby's body. So this is depicted here in this cartoon. You can see we've got spinal nerves and the meninges herniating outside the body. There's no tuft of skin covering it, so this is an example of an open neural tube defect. In this condition, usually you get neurologic dysfunction because of spinal cord nerve herniation, so lower extremity motor and sensory deficits are common. In addition, many babies who have myelomeningocele also have a Chiari-2 malformation, which we're going to talk about later in this video. This is a posterior fossa congenital malformation involving the cerebellum. As I said, myelomeningocele is an open neural tube defect where there's no skin covering the meninges and the spinal cord. You have exposed spinal cord nerves covered by a thin membrane, and the baby is, once again, just like in meningocele, born with a little fluid-filled sac at the base of the back. But in this case, the fluid-filled sac contains nerves from the spinal cord. And so here's a cartoon just to make this super clear. This is how the spine should form with the vertebral arch closed over the spinal cord. This is what happens when you get normal closure of the caudal neuropore posteriorly. In spina bifida occulta, you're missing the vertebral arch, but nothing is herniating, and the only evidence of this condition is that little tuft of hair over the skin at the lower back. In a meningocele, you have the meninges poking out, but they're covered by skin, and the spinal cord remains where it's supposed to be in the spinal column. And then in myelomeningocele, the most severe form of spina bifida, you have herniation of meninges and spinal cord nerves to outside the body. You don't have skin covering the defect, so it's an open neural tube defect. The defects related to spina bifida can often be detected in utero, usually by ultrasound, and there are surgeries to repair the defects. Some of these can actually be done prior to delivery in utero, although more often they're done after birth. And the main problem with spina bifida is that it can lead to permanent neurologic deficits, especially weakness or paralysis of the legs that make people wheelchair-bound. And this is because the defects usually involve the lower spinal cord where there is protrusion of the spinal cord and the meninges through the defect. You can also see bowel and bladder problems. The problems are all going to be related to the lower extremities in the pelvis because that's below the region where the nerves of the spinal cord are affected. Okay, next let's talk about anencephaly, which is not a form of spina bifida, but this is another example of an open neural tube defect. In anencephaly, there is failure of the anterior neuropore to close. So remember, the neural tube is a long tube. One end is called the posterior or caudal end. Failure of this end to close is what leads to spina bifida. In anencephaly, it's the other end that fails to close. This is called the anterior or rostral neuropore, and this leads to formation of the brain and the skull. And so when you have failure of the anterior neuropore to close, that leads to failure of the skull to form around the brain. And this is going to lead to a very severe form of neural tube defect. It's the most severe form, and it's not compatible with life. Basically, what happens is the forebrain and the brainstem are exposed in utero because they're not surrounded by tissue and bones. As a result, they're going to fail to develop, and when the fetus develops without a functioning forebrain and brainstem, it will end up being stillborn or it will die shortly after birth. Some other things to know about anencephaly are shown in this slide. So first of all, the bones that fail to form when the anterior neuropore doesn't close are called the calvarial bones. These are flat bones that form the roof and sides of the skull. So the calvarial bones are bones like the frontal bone and the parietal bone and the occipital bone, and they will fail to form around the developing central nervous system around the brain region. And so for this reason, the classic ultrasound finding is called an open calvaria, which basically just means absence of parts of the skull, the calvarial bones. When the brain and brainstem don't develop normally, the fetus takes on what's known as a frog-like appearance. This is a picture of what it can look like here. You can see the developing eyes without a brain around them. And then finally, you should know that the mother, when the fetus has anencephaly, is going to develop polyhydramnios. And that's because the baby can't swallow fluid normally, and the way that the amniotic fluid level is maintained in the mother is that the fetal kidneys produce the amniotic fluid and then the baby swallows that. But that's not going to happen normally when the brain and brainstem don't develop as they should. Sort of related to anencephaly is another neural tube defect called an encephalocele. This happens when there's a partial failure of the anterior or rostral neuropores to close. And the key word here is partial. In anencephaly, there's a complete failure of the neuropore to close, and that leads to the severe neural tube defect anencephaly. In encephalocele, there's only a partial failure, and as a result, you get many of the skull bones forming normally, but they're incomplete. And as a result, the brain and the meninges can herniate through defects in the skull. This is relatively uncommon. It's the least common neural tube defect, but the most common site where the brain and meninges herniate through a skull defect is in the occipital bone. And so when that happens, the baby's going to look something like what you're seeing here. There's a defect in the skull back here. It's allowing herniation of meninges and brain tissue into a fluid-filled sac at the back of the skull. There's a blood test that can be done in women when they're pregnant that can be helpful in early detection of neural tube defects, and that blood test is alpha-fetal protein. So this is a globulin, meaning a globular protein that's produced by the fetus. It's specific to the fetus. It's made by the growing fetal yolk sac and the fetal organs. Its exact function in the baby is unknown, but it's excreted by the fetal kidneys, and some of it finds its way into the maternal circulation where it can be detected by a blood test. So at around 16 to 18 weeks of pregnancy, you can measure the maternal serum level of alpha-fetal protein by doing a blood test on the mother. And that level can be elevated in women who are pregnant if their fetus has an open neural tube defect. And the key word is open. So the level of AFP can get very high if the baby has a meningomyelocele or anencephaly. Those are the two open neural tube defects we talked about. In contrast, the level is not usually elevated in spina bifida occulta or meningocele because those are closed neural tube defects where there is skin that covers the defect, and this prevents leakage of alpha-fetal protein into the maternal circulation. Now, in actual practice, you need to be aware that if the level of alpha-fetal protein is high, this may indicate a neural tube defect, although it does not definitely indicate that one is present. The interpretation is complex and follow-up tests are often done. But what you want to know at the step 1 USMLE type level is basically that the alpha-fetal protein level can go up in open neural tube defects. Okay, next let's talk about holoprosencephaly, which is another neurocongenital defect, but this is not a neural tube defect. Holoprosencephaly is classified as a cephalic malformation, and the cause of this condition is failure of cleavage of the prosencephalon. We talked about the prosencephalon earlier in this video. It's one of the vesicles or bulges of the early neural tube, and it goes on to develop into the brain. And it should be cleaved in half to form the left and right hemispheres of the cerebral cortex. This usually happens around 5 to 6 weeks of development. But if that cleavage doesn't happen, then the baby can be born with holoprosencephaly. You should be aware that in the basic science literature, there have been a number of studies showing that the reason the prosencephalon fails to cleave normally in holoprosencephaly is because of failure of certain signaling molecules. One of the molecules that's been implicated a number of times is the sonic hedgehog protein. And when a baby is born with this condition, the key findings that you're going to see are facial abnormalities. You won't be able to see that the brain has not cleaved in half normally. There are often abnormalities of the face that are obvious. One of the things that many babies with holoprosencephaly have is a cleft lip or palate. That's what's shown here in this image. You can also see cyclopia, which means presence of only a single eye. And I'll show you some pictures of that in just a second. Holoprosencephaly often occurs together with some other developmental syndromes. So for example, you can see it in trisomy 13, trisomy 18. You can also see it in children who have fetal alcohol syndrome. And beyond the facial abnormalities, the fact that the prosencephalon doesn't cleave normally often leads to other neurodevelopmental problems. So these babies can go on to have developmental delays and sometimes seizures. So shown on this slide are some of the variants you can see in holoprosencephaly. You don't need to know all these for step one. I'm just showing them to you so you can have a picture in your mind. So this is a normal brain. These dark regions are the ventricles, and you can see that the brain's got two lobes with divisions going down the middle. This is an alobar brain with only a single lobe. And then there are a number of other variants that are shown here in this image. And then here's a picture of some of the different facial anomalies that you can see. So cyclopia is shown here in A with a single eye. In B, you can see this child has no nose. In C, you can see that the child has a nose, but only a single nasal passage. And then there are other variants shown here along the bottom. Some of the less severe variants include simply a cleft lip, like shown here. And you can see here in G, the child has a single tooth, but that's basically the only obvious facial abnormality. Okay, moving on. Next, let's talk about lissencephaly, which is another neurocongenital disorder. This is also not a neural tube disorder. This is considered a disorder of neuronal migration because it's caused by a failure of neurons to migrate to their normal place in the brain. As a result, these children are born with a smooth brain that lacks the normal gyri and sulci you expect to see in the cerebral cortex. This is an image of what it looks like on the slide here. If you look at this brain, you can see it's just very, very smooth. It doesn't have the normal bumps that you expect to see in the cerebral cortex of a normal human brain. And so some of the clinical consequences of this failure of neuronal migration are summarized in these bullet points here. So these children can have problems swallowing, they can develop seizures, they can have a very small head circumference, that's microcephaly, and then they also can be born with a number of different facial anomalies. Okay, moving on. Next, let's talk about Chiari malformations, which are anatomic anomalies that involve the cerebellum and then also sometimes the brainstem and often the craniocervical junction, which is the junction between the skull or the cranium and the cervical spinal cord. Chiari malformations are a group of congenital disorders that are numbered. So there are Chiari 1 malformations and Chiari 2 all the way up to Chiari 4. There are only two of them that are important to be familiar with that we'll talk about in this video. And in most of these Chiari malformations, one of the key features and common features is downward displacement of the cerebellum. So we'll start by talking about a Chiari 1 malformation, and this occurs when the cerebellum develops with an abnormal shape to the cerebellar tonsils. The tonsils are small, rounded structures that you find at the bottom of the lobes of the cerebellum, and when they develop abnormally, that can lead to a Chiari 1 malformation. What's bad about having an abnormal shape of the cerebellar tonsils is that they often get displaced through the foramen magnum, and the foramen magnum is a key component of the craniocervical junction that we were just talking about on the last slide. That's the junction of the skull base, the cranium, and the cervical spine. And so if you look at this image on the slide over here, this is the cerebellum back here, and the rounded bottom are the cerebellar tonsils, and they have an abnormal shape, and that is causing the tonsils to be displaced downward through the foramen magnum, and that's what you get in a Chiari 1 malformation. Now, one thing that's super high yield to remember about Chiari 1 malformations is that they are highly likely to be associated with syringomyelia, which is the development of a fluid-filled cavity in the spinal column. This is a picture of syringomyelia right here, and we'll talk more about this in just a second, but it almost always goes hand in hand with Chiari 1 malformations. So one of the things that's strange about Chiari 1 malformations that you have to remember is that even though Chiari 1 malformations are congenital anomalies, they usually don't produce symptoms until adolescence or adulthood. The mean age when symptoms begin to develop is 18 years, and that's because the cerebellum has to grow in size to reach a point where it starts to cause symptoms. One of the first symptoms many people develop is headaches. This is caused by meningeal irritation. Classically, the headache can be worse with a cough. This is obviously called a cough headache, and this can be a symptom of a Chiari 1 malformation. Other symptoms that can occur in young adults who develop symptoms of this condition are cerebellar dysfunction, so various forms of ataxia and loss of balance. And then the displacement of the cerebellum through the foramen magnum can compress cranial nerves, so you can get cranial nerve dysfunction in various different forms. Now, I mentioned this before, but it's super high yield to remember that Chiari 1 malformations are commonly associated with syringomyelia, which is a spinal cord condition I talk about in the videos on spinal cord disorders. Syringomyelia refers to development of a syrinx, which is a fluid-filled cavity in the spinal cord. This usually happens in the upper spinal cord with the nerves that supply the arms. So this often leads to sensory loss in a cape-like distribution, which means a distribution that affects the bilateral upper extremities, and usually it's sensory loss related to pain and temperature. And once again, I talk about syringomyelia in detail in other videos. Okay, moving on next, let's talk about a Chiari-2 malformation, also sometimes called an Arnold-Chiari malformation. This also involves downward displacement of the cerebellar tonsils, but in addition to the tonsils, in a Chiari-2 malformation, you have downward displacement of the vermis, which is a midline structure in the cerebellum that I talk about a lot in the video on the cerebellum itself. Besides displacement of the cerebellar tonsils and vermis, there are two other key clinical features you have to remember about a Chiari-2 malformation. One is that it's associated with brainstem malformation. Classically, the midbrain appears beaked on neuroimaging. And then finally, Chiari-2 malformations almost always go hand in hand with a spinal myelomeningocele. That's the neural tube defect we talked about earlier in this video. These are often detected prenatally or at birth, and so when one of these myelomeningoceles is detected, then often investigation is done to image the cerebellum, and that's where you can identify Chiari-2 malformations. Because of the displacement of the cerebellum, most babies with a Chiari-2 malformation develop non-communicating hydrocephalus. So to understand this, let's look at this drawing of the ventricles of the brain shown right here. So this is the cerebellum, and when it's displaced and compressed downward, it can compress the fourth ventricle. It can also compress the cerebral aqueduct shown here. So that will block the flow of cerebrospinal fluid in this direction. As a result, you get enlargement of these ventricles up here, which are the lateral and third ventricles. They can become dilated. That's non-communicating hydrocephalus. And then because of the myelomeningocele, the neural tube defect, these babies often develop paralysis of the legs below the level of the defect. And then one of the most striking features of children with Chiari-2 malformations is the enlarged head circumference, which is shown here in this picture. This happens because of the hydrocephalus. So they may say in a board question that the anterior fontanelles are distended or the sutures are widely split. These are just ways of describing large head circumference. There's also a clinical finding that you can see in these babies called a cracked pot sound, also known as McEwen's sign. It's basically abnormal percussion when you percuss the skull. You can see this with any form of hydrocephalus, but it's a classic finding described in children who have hydrocephalus from a Chiari-2 malformation. Okay, our final neurocongenital disorder for this video is a Dandy-Walker malformation. This occurs when there's hypoplasia or agenesis of the cerebellar vermis. So the vermis, as we talked about before, is a midline structure of the cerebellum. And if it is underdeveloped or doesn't develop at all, that can lead to a Dandy-Walker malformation. This is believed to occur because of failure of midline fusion of embryologic structures called the rhombic lips. These are neuroectodermal structures that fuse to form the cerebellar vermis. And if that doesn't happen, you can get a Dandy-Walker malformation. When the cerebellar vermis is either underdeveloped or not developed at all, this leads to major anomalies of the fourth ventricle. In particular, the fourth ventricle expands and becomes enlarged, and it also forms cysts. And on neuroimaging, one of the most obvious features of a Dandy-Walker malformation is the massive fourth ventricle. That's what's shown right here in the back of this child's skull. You can also see in this image that the cerebellum is very small and underdeveloped. All of this fits classically with a Dandy-Walker malformation. And then the cysts that form in the fourth ventricle lead to hydrocephalus. So you get a dilated cystic fourth ventricle, and the cysts obstruct flow of CSF out of the lateral and third ventricle, so they become enlarged as well. So really, the most important thing to know about this condition is what it looks like on neuroimaging. It's fairly easy to recognize. This is a very rare condition. Children who do have this problem have many, many associated symptoms and other problems. They have hydrocephalus, as we've already discussed, but they tend to have delayed development, intellectual disabilities. They have motor dysfunction. They will have delayed crawling and walking. They can have seizures, and they can also have a number of different vision problems. And all of this is related to the fact that the cerebellum was underdeveloped, and that leads to fourth ventricle problems and hydrocephalus. And here's a couple more images of this condition just to show you how obvious the enlarged fourth ventricle is. You can see this enormous fourth ventricle here. You can see another one here. These are all classic findings that you could see in a person with Dandy-Walker malformation. And that concludes our video on neuroembryology.